50% fatalities that don't make it to the hospital is related to chest trauma. The nice thing is most of the chest trauma that we treat for trauma is easily treated typically in the trauma room, and they don't require the operating room for most of them. So these are typically like, pneumothorax, tension pneumothorax, rib fractures, pulmonary contusions, sometimes sternal fractures, clavicle fractures. Only a small percent actually have to go to the operating room. Typically that's some sort of cardiac or myocardial injury or some sort of great vessel injury that we actually have to take to the operating room, or it involves something that, within some sort of vasculature within the neck or esophagus. All right, let's look at some chest x-ray. What do we see on this one? Does everybody see, what do we see first? He's probably angled a little bit, rotated, which can throw off some of your visual measurements on there, but he's obviously got like a mid-clavicle fracture. And then, you guys notice like the discoloration between the lungs there? How one of the lungs is a little bit more white. That's what a pulmonary contusion looks like. So, and then you guys see like the many rib fractures there? You guys sure? Because these aren't that's not the fracture there. So a lot of times we confuse some of it. We confuse where they are or how we're looking at them. Like up here, you actually have like a displaced fracture there. It's kind of hiding, but it's like completely displaced, and it looks like there's basically two segments there. So, and then you got one hiding under here, and then these are those subtle indicators I was talking about, those subtle findings. So there's multiple rib fractures down here that you may not see. You may not see the rib fracture, like it's not glaringly evident on chest X-ray, but that little bit of air can kind of cue you in that something's going on. You got some air leaking into those soft tissues there, so there's something wrong. All right, so like we said, this accounts for a lot of early deaths, a lot of especially blunt trauma. We're talking about mostly motor vehicle crashes or some sort of fall from some height, but typically it's the early deaths are from some sort of airway obstruction, flail chest, pneumohemothorax, and then some sort of cardiac tamponade. Sometimes like one of the great vessel injuries or one aortic injury is certainly one of those injuries that often don't make it to the hospital. We do a little bit better now because we have shoulder straps on our vehicles, but still a lot of people don't wear them. My son included, and it irritates me, but we won't go there. But obviously car versus pedestrian, that's always bad. That's always bad. It doesn't matter how fast you're going, you hit somebody, it's usually bad. And then we talk about some of our history there. If the patient is stable, obviously our examination is going to be guided by our primary survey, so some of this we may not get till afterwards, but we do like to get that ample of history if we can. And then a lot of times if we're going to do some sort of thoracotomy on these patients or laparotomy, we tend to prep both areas if they're going to require surgery, because a lot of times those injuries, they can have multiple injuries, and so a lot of times with the thoracotomy, we'll also open up the abdomen for an X-lap just to explore for any bleeding that we might find in there, just because it's hard to differentiate initially on exam. So they'll typically we'll do a chest thoracotomy, we'll cross clamp the aorta, and then we'll take them to the operating room. A lot of times before we even do the thoracotomy, we put bilateral chest tubes in these trauma patients as well, so that's a very common procedure to see. Oh yeah, fire alarm. It's not a real one, it's all fake. Fake news. Fake news. Not a fire alarm. Alright, so our physical exam, obviously we're in the breathing portion of our physical exam, so what are some things where we might see during that airway and breathing So you can definitely, they might have some cyanosis. You might be able to palpate some subcutaneous emphysema. You typically, a flail chest, obviously on the anterior portion, is usually extremely visible with like dysynchrony and breathing. And then obviously any lacerations, hematoma, JVD, tracheal deviation. Also on your physical exam, well, we'll go to that one next. So like on your palpation exam, obviously is pretty glaringly obvious here. That patient on the, what is it, bottom left there, so he has a chest tube, and I've definitely done this in the trauma room. You see an entrance and an exit wound like that, and we drop a chest tube, and come to find out later, it actually, the bullet just kind of like skated around the ribs and came out, and we're like, oh, well, no harm, no foul, hopefully. So, sometimes we do play, like I said, it's a clinical diagnosis. So he probably had something else going on that caused some sort of instability, which required the chest tube. And maybe he needed it in this one. It did penetrate the thoracic cavity, who knows. But that definitely happens in our trauma rooms. And then obviously we want to look for signs like upper airway obstructions. Are they cyanotic? Are they gray? You have gurgling sounds, stridor, and then obviously we're looking at the chest, so our visual inspection is very important. Do we see equal rise and fall of that chest as we're looking at it? And then we can also, palpation also helps with that exam. And then another one we need to look at is like, do we see any accessory muscle use with these patients? Do they look like they're struggling to breathe? That's another indicator that there might be some sort of airway, some sort of breathing difficulty there. Commonly, like if a patient presents stable and they have a tension pneumothorax, a lot of times like they'll be very anxious. Then usually they'll be tachypneic, but they otherwise might be stable. Those are some of typically the first signs I see, and they start looking real anxious. They start increasing their breathing rate. Then you see some of that accessory muscle use. And then, depending on how large it is, you'll see that hypotension and everything kind of goes south after that if we don't treat it immediately. I want to know what happened to that kid with whatever that is, broomstick or something in there? Javelin? I don't know. Alright, so like I was saying, you want to palpate the chest wall, you want to look for chest expansion, any sort of crepitus, tenderness. You feel that little crackles, a subcutaneous emphysema. And hopefully, usually an open pneumothorax is hopefully very obvious, and you can see some sort of penetrating entrance wound or exit wound. Obviously, if you find one, you need to search for the other in these patients. And we'll talk about some of the other places that these injuries might hide. And then your breath sounds are going to be very important. And sometimes with a pneumothorax, they might not be completely absent, but they will be diminished, which can be very difficult because there's a lot of things going on in the trauma room at once. The airway, the head of the bed's calling out airway findings, right side's calling out their findings, left side their findings. So, but that is another good indicator for you. It's diminished on one side. And then obviously anything like muffled, displaced, crunching, hard sounds, indicative of some sort of myocardial injury. All right, so our posterior inspection is very important. So we always have to log all these patients. We need to rule out any trauma on that posterior thorax, and this is a lot of times where those injuries can hide, or especially those exit wounds or entrance wounds, depending on where they were shot. So it's important that we lift up those axillas and we're actually visually inspecting and palpating those areas. Just doing a quick blood sweep of it is not going to be sufficient, because that with them, with their arm down, they might be occluding that bleed in the axilla, and then you may have a normal blood sweep, but there's still some sort of penetrating wound to that area, whether it's an entrance wound, exit wound, stab wound. So it's important that we actually lift their upper extremities above their head and actually look in those areas, because they can hide. Other areas commonly are those like gluteal folds. They can hide, especially in your larger patients. So it can be difficult when you're treating these patients, and it is important to check all of these areas, so don't overlook it. All right. What is our first priority with trauma? What do we think? Airway, yes. All right. Are we all understanding that? Hopefully, maybe. All right. And are we going to do all those other things during our primary survey? Yes, probably. But we need to start at the beginning with our airway, and we need to treat anything that we find along the way. So, any life-threatening injuries, we treat that first before we move on to our primary survey. Now, we normally have a trauma team where we're all doing it at the same time, but when you guys, if you ever find yourself in a role 1 somewhere, you may be the only provider there, and if you haven't trained your medics, and they're great at PMCS and vehicles, but not really medical treatment, then you may find yourself doing this alone, which is no bueno. All right, like I said at the beginning, most chest injuries are actually treated non-operatively, so obviously fractured ribs, sternum, clavicle, most of them are treated non-operatively, or they're treated non-operatively initially. Now, we're not considering orthopedic operations here, so sometimes they might end up having to see the bone doctor. But as you guys, if you remember from your ortho class, there's like 7 emergencies, and those aren't really emergencies to them. So a lot of times they'll treat that later. Like I had it was like 3 centimeter displaced clavicle fracture a couple weekends ago, and it hadn't broken the skin, but obviously it's not an emergency. And I was like, yeah, ortho will follow you up in a couple weeks. And the guy's like, I'm just supposed to walk around like this? I was like, yeah, pretty much. I'm not the bone doctor, but it's not an emergency today. You're gonna have to deal with it. Stop riding motorcycles. Sorry, no offense to motorcycle riders. That's just, we treat a lot of them. All right, so important injuries we're looking for, obviously pneumothorax, pneumothorax, those pulmonary contusions, which sometimes may not be evident, which we'll talk about in the next few slides. They may not be evident initially, and it may eventually become evident a few hours later. And then looking for any like blunt cardiac injury, aortic transections. If the rib fractures are significant, you should be able to feel them on palpation. Sometimes the only thing you'll notice on palpation is they have pain in a specific pinpoint area, and that can kind of guide you to where that rib fracture might be. They may have some crepitus, they may have some sort of deformity on there, but not often. So you'll find a lot of those rib fractures after the fact on your chest x-rays. And then we have those sentinel injuries, which is what we call it takes a significant amount of trauma or force in the mechanism to do these, and they usually portend other injuries or concomitant injuries. So that's like a first rib fracture, scapula fractures, it takes a lot to fracture those areas, sternal fractures, and then bilateral rib fractures. Lower rib fractures are less common too. For a lot of these injuries. And then these patients do have a lot, they have a ton of chronic pain and other sequelae that can irritate them and cause a lot of disability later on down the road with these fractures. So the only ones we typically treat surgically, like we said, that over 1.5 liters of blood loss through your chest tube, like diaphragm ruptures, transected aorta, tamponades, esophageal perforations, and then significant tracheobronchial injuries, which those are less common, but they will require surgery. So what do we do for these patients? Everybody gets a chest x-ray. So that's one of our adjuncts to our primary survey. Typically when we go through our A, B, C, D, E, when we log roll that patient, we throw an x-ray under their chest and sometimes their pelvis too, and we get a plain film right then. So it does usually happen immediately. And like I said multiple times, you don't need a chest x-ray to diagnose a pneumothorax or a hemothorax. Those are a clinical diagnosis, and you can treat accordingly with chest tube or needle decompression followed by chest tube. But as you can see, what do we see on all these films here? What is it? What's that top right one? Yeah, yeah. Hemothorax, would you say it's tension physiology? You guys agree? Disagree? Yeah, yeah, yeah. Significant tension physiology on that. What about the bottom left? Yep, another hemothorax on there. And then, what are we seeing on that bottom right one? Yeah, looks like a pneumothorax. He's definitely got multiple displaced rib fractures there. All right, so the most common injury we're going to see are those rib fractures. And what we need to assess is obviously how much pain is the patient in, and are they splinting? So what that means is like, are they not able to take an adequate breath? So you might see them taking like little breaths, like, or they're not able to take a deep inspiration. So those are important physical exam findings we need to look at when we're evaluating these patients. And then, is it preventing them from having an adequate cough? So these are all criteria we use in these patients, which we use what we call our PIC score, which is pain, inspiratory, effort, and cough. So are they able to take deep inspiration? How bad's their pain? And do they have an adequate cough? And that kind of guides our management, and we monitor that score as we're evaluating these patients and deciding whether they need to stay in the hospital versus they can be managed outpatient with just some sort of oral analgesics and pain control. If if your diagnosis is equivocal or you're unsure, you can get a CT of the chest, which we typically are in these blunt trauma patients. But sometimes isolated injuries, we may just only get a chest X-ray. They have a rib fracture. They're completely stable, and we ruled everything else out. On our physical exam, we may not go for the CT, but if there's any concern, then we get a CT of that patient. And then the chest wall strap-in, taping, bracing, like that's never been a thing. I don't know why we still say you can't, like, don't do it. Like, it's, I've never seen it done or anybody think about doing it. I don't know if it's something on TV. Is that something you guys have seen? Like, oh yeah, let's wrap the patient. Let's wrap the patient's chest to help with this. I've never seen that, but apparently it used to be a thing, and people somewhere still think it's a thing. Very few people get rib fixation, but that is definitely an adequate treatment. But it's less common just because we can manage these patients usually with pain control. So sometimes we may have to give them an epidural and talk to anesthesia. We do like to use pain pumps on them and give them, a significant amount of pain control, just so we can avoid those secondary complications like atelectasis, pneumonia, and then multiple rib fractures. Typically, in a young, healthy patient, can be managed as an outpatient. When usually, like our rule of thumb is if they're over 65 and they have more than 2 rib fractures, we like to keep them in the hospital. Depending on their PIC score, we may send them to the ICU for further management, but we typically keep all of those just because they have a higher likelihood of getting, having some sort of infection afterwards. And then our flail chest. So yeah, 2 ribs, fractured in 2 or more places. It creates that segment that causes paradoxical respiration. Usually pretty evident on physical exam, especially on the anterior thorax. So we need to, typically our physical exam is all we need, but we do like to get a chest X-ray on these as well. And then we have to decide what we're going to do for these patients. So, we try to avoid intubation as much as we can. So we typically start with good pain control. But we also need to look, obviously, at their vital signs, look at their VBG is another great test we're going to get for this. And then we need to consider whether we can manage them with pain control versus whether we need to place them under sedation and decide to intubate these patients. So typically we only do that if some sort of respiratory compromise develops. We like to manage them less invasively or non-operatively to start with. And then typically when we admit these patients, we have what we call, like, everybody understand like that pulmonary toilet when we have all these chest physiotherapy techniques. We have it almost looks like a puck. They set it on there and it actually percusses the chest, and that helps get some of those whatever sort of inflammation they have in the lungs or any fluid in the lungs, and it kind of helps them cough that up or remove it. And then we tend to hourly, they have to use their incentive spirometer and take a deep breath, and that's kind of what we track throughout their hospital course and for their improvement for these patients. But anybody with like worsening hypoxia or hypercarbia, despite the adequate pain control, we tend to take their airway and use mechanical ventilation for them. And for these ones, we like to have a high FiO2, and then we adjust the peak accordingly until we can get, till we have normalization of their vital signs. All right, sternal fractures. So it takes quite a bit of force to cause a sternal fracture. The good news is most of them can be managed non-operatively unless there's some sort of displacement. So we will see some isolated fractures, but the concern with sternal fractures is the amount of trauma or force it takes to cause this. We need to then rule out all the other intrathoracic injuries that can be accompanying it, whether that's cardiac injury. So that's usually our biggest concern is, do they have any sort of cardiac injury? So obviously we start with our ABCs. If that patient is unstable, we have an isolated sternal fracture, we get an EKG on them. Obviously we've gotten a chest x-ray. And typically if we have a normal EKG, then it's unlikely that they have any sort of serious injury to the myocardium. And then we just manage them typically with pain control. We manage them on an outpatient basis. Usually with an isolated sternal fracture, it's very stable in the area that it's located, so we don't typically worry too much. Now, some of the concerns we have are when we have dislocations, especially of that like SC joint. You can see that one, especially when it's dislocated posteriorly, that can cause significant concern. So we do want to make sure we're ruling that out as well during our exam. And then, like I said, most of them deal without treatment. They can do an open reduction internal fixation on these patients. Anybody for non-unions, that's obviously going to be later down the road as the fracture doesn't heal or isn't healing appropriately on the follow-up x-rays. They may have to get an internal fixation for those. And then obviously anything severely displaced, anything displaced going into the thoracic cavity, multiple unstable rib fractures, those ones will likely get some sort of internal fixation. And then if we're doing a thoracotomy as well, we may consider doing an internal fixation on those ribs. All right, so pneumothorax. This is going to be probably one of the more common ones we treat after blunt trauma, pneumo, and hemothorax. So some sort of injury to the lung or tracheobronchial tree results in air in the pleural space. And thankfully, it's easy to diagnose. Chest X-ray can show, a pneumothorax, even a small one. The chest X-ray is very good for that. Or one that's small enough to cause any sort of like tension physiology or derangement in your vital signs. Typically, we can see that on a chest X-ray, which is great. You can also do your EFAST looking for lung sliding as well. And then these are easily treatable with a tube thoracostomy, which we'll talk about in the lecture after this. Typically, there's different guidelines, even Up to Date has different recommendations. Some use whatever the Thoracic Society is, some use other indications. Typically, 20% is anything smaller than that. We typically we don't manage with a chest tube. However, if they have any sort of respiratory distress or we have any concerns on their vital signs, we may put a chest tube in them. If we don't, for simple pneumothoraxes, we'll a lot of times monitor in the hospital with oxygen and serial examinations and chest x-rays. If the diagnosis, or if you're concerned, or maybe they have other comorbidities that you're concerned about, like a COPD patient or something like that, they got multiple blebs, sometimes we'll get a CT scan on them for these patients as well. All right, and then our tension physiology. So this can be caused from progression from a simple pneumothorax, or they might present with a tension pneumothorax. These are certainly life-threatening, and you're going to see your tension physiology, especially, first off is seeing their vital signs and the respiratory effort on your physical exam, but then obviously your chest x-ray is going to show some sort of finding on there, like you see on that upper right chest x-ray. It's pretty significant rib fractures on there. What else do you guys see on that chest x-ray? You have your tension physiology, you've got like multiple rib fractures, a lot of subcutaneous emphysema on there. And then they got a CT scan. Not sure if that's the same patient or why you need a CT scan to help differentiate that, but that's on there. So, typically on physical exam, you'll have that, especially when it's a tension, you'll have that unilateral chest wall expansion. You usually have absent or significantly decreased breath sounds. You can have tympany. And then you see that like tracheal deviation is a late sign. I don't know that I've ever been able to see it on physical exam, but we definitely see it on the chest x-ray. It's a little bit more difficult or a later finding on physical exam. And you certainly can see like distended neck veins, and then you have your early signs that we typically see this is why we treat this without our x-rays, like if they came in hypotensive, they're tachypneic, tachycardic, and we have a mechanism. I mean, obviously on physical exam, you should certainly be able to, on how significant this patient's is, you're going to certainly have that crepitus with those rib fractures on likely unilateral chest rise with how large that one is. And then that patient's vitals are certainly going to be tanked. And then our treatment, so for tension pneumothorax, our initial treatment, they're going to get a chest tube. Whether we do a needle thoracostomy first is going to be, situation dependent, but the definitive treatment is going to be a thoracostomy tube in these patients. Now, sometimes we might do like a finger thoracostomy, which is basically doing the same thing as a tube thoracostomy, except you don't put the tube in, you just stick your finger in, and this is a more emergent procedure. This is why a lot of times in the trauma rooms, like we all carry scalpels in our pockets, and we're prepared to do this intervention relatively quickly, just to alleviate some of that air or blood that they may have in the thoracic cavity. And then, like I've said many times, don't wait for a chest x-ray if they're obviously not stable. You need to do the chest tube prior to that chest x-ray. And yeah, there is a lot of debate on needle chest decompression. Especially with the second intercostal space, like initially at the beginning of the war, I've stuck, I think like four needles in a guy and still didn't get any relief. I didn't have a chest tube, but like it's not like the movies. You place that needle in there, you hear this air, all right, it feels better. You've ever seen Three Kings when there's a little valve? They're typically not like that. So yeah, I put a needle in, didn't get anything, put multiple needles in, nothing happened, and then we had to evac, obviously, for a tube thoracostomy at that point. So there is debate whether it works or not. There's also, there used to be some debate. Maybe there's like a skin plug in that needle. There's a lot of talk about it. So they actually have newer little devices that can monitor air. An easy way is having like one of your flushes and it's half filled, and you pull the plunger out of it. You might see air bubbles can help you in those situations where you can't do a chest tube and it's kind of loud, or if it's more of a like combat environment or TC3 environment. That's another useful way you can tell whether that needle was appropriate or actually reached the thoracic cavity or the pleural cavity and is actually evacuating air out of there. All right, I'll give you all a second to read this one. It's long. All right, is this patient stable, unstable? What do we think? By the information given, yeah, stable. Yep. So, what are we gonna do for him? Yeah, the observation and oxygen, further treatment may not be needed. What if this patient was unstable, what would we do? Yeah, C. Yeah, but what if we said, so that's where it gets tricky, right, with these questions, like what if I said like, what is the most appropriate initial treatment? It's a bullshit question, right? But that's what we do. And this question's long, the pants questions are like twice as long, they're ridiculous. Like, you sit there reading them forever, like I did my pan read, and I just like would read the last sentence on what they're asking me and then go back to the top to find something, because they were, you have to scroll your page on the computer, you're like, yeah, they're long. They like put a lot of information in there. All right, so open chest wound, so a sucking chest wound is another name we like to call it. So it depends on the size of the wound. Like the rule of thumb is, if that hole is larger than 2/3 of the tracheal diameter, your respiratory effort will move air through that hole versus through the trachea. So, and then air is going to leak into the chest and it's going to collapse the lung. So our initial priority in treatment in this is we need to place some sort of occlusive dressing on there so we stop that airflow into the thoracic cavity. And then you can see like there's so many different dressings out there that we use. I would say the bottom left is probably the most common. It comes in your medical equipment set, so make sure you guys know how to use the Halo. It's very uncomplicated, it's just a piece of plastic with some really good adhesive material on it. We used to use that top right one called the Asherman chest. That was the first one I ever designed. It didn't stick to anything, it was annoying. If you had any sort of blood, any sort of perspiration, that thing just fell right off. And then you have those like Bolin chest seals, which is supposed to have like a one-way valve on it. So you may see those as well. Those are pretty common. The one on the bottom right, the hyphen, that's like its fifth design. The first one they made was what we had in the medical equipment sets, and come to find out, when it's like really cold and if it gets frozen in Afghanistan, the stuff stopped, the adhesive material didn't work anymore. We were like, holy crap, this doesn't work anymore. So luckily it comes with like a plastic. Comes in a plastic package, so you can just take the package on there if all else fails. So you can make one of these out of just about anything that provides some sort of occlusion over that area. And then there is, some debate. We try, if it is avoidable, we try not to use that sucking chest wound to place our chest tubes in. So that's, sometimes, there is some debate on it, but that's typically our recommendation. Sometimes that's the only option though, depending on how large that wound is in that area. But we typically try to avoid it, so we may go a little bit higher, or a little bit like superior in that area. We try not to go inferior unless it's a higher injury, because then we worry about the diaphragm and sticking some sort of chest tube into the belly, which is poor form when delivered. We don't want to do that. Don't be that guy. All right, and then hemothorax. So these ones require a tube, typically a large bore tube. There are some recent studies that show a smaller bore works as effectively, but most of the time you're going to have a 36 French, sometimes 32 French are going to be like the two options. The medical equipment sets in the Army only come with a 36, so that's really your only option there. You don't have those smaller ones, which we call the smaller tubes, like a pigtails or other ones we use. And they are just like, they range from like 18 French up to, your 36 are typically what we're doing for these. And then obviously our initial management, if we get more than that 1,500 milliliters of output, more than our 200 milliliters an hour of continuous drainage, then we need to think about whether we need to do some sort of thoracotomy, because they have a significant bleed going on in that chest that isn't, that's not healing on its own or not clotting on its own, so we need to open that chest up. So those are our thoracotomy indications. And then there's obviously complications, you know, retained pneumothorax, you get that atelectasis, empyema. If there's any, you know, concern, CT is going to be our best test to help kind of identify these more occult ones that aren't obvious on physical exam and they're stable. And then pulmonary contusion. So this is like commonly associated with blunt trauma, and especially like those rib fractures, you'll see an underlying pulmonary contusion, and it causes a profound like ventilation perfusion mismatch. So this can be pretty significant. Typically, if it's large enough, we need to admit these patients to the hospital, and they may have everything from like shortness of breath all the way up to respiratory failure, and we have to intubate these patients. But it does cause, you know, an inflammatory or immune response, and sometimes initially it may not be evident on the chest X-ray, and it may develop over, you know, a few hours after that patient is admitted to the hospital. So it's always something we're going to watch out for. And a pulmonary contusion is a significant risk factor for pneumonia, so we always want to consider that as well. We don't do a lot for them other than monitor, typically give them some oxygen and then serial exams and supportive care, and they typically resolve over 3 to 5 days. And then thoracic duct injuries, these are uncommon. However, they can be associated iatrogenically with procedures we're doing, and we've seen them with central lines. So when we do like a subclavian central line, it's right in that area, and we're doing it, you know, right next to the clavicle, and there's a lot of structures that can be damaged in that area. So especially like you need to consider when you're doing your if you're doing a left central line into the subclavian, this can certainly be associated with it. Traumatic hylothoraxes are typically less common from the trauma, typically it's still from us causing this. And then it causes, really what happens is you get those chylomicrons and the triglycerides like we talked about during our pleural effusion lecture. And you can get quite a bit of drainage out of here, and this is typically that like milky or whitish drainage that you're going to see with these patients when you're evaluating them. If they have, you know, if they're draining a significant amount a day, like, you know, more than a liter, this can cause like a significant immunal response. So a lot of times these patients, those patients will go to the operating room to get that repaired. But if they're stable, we typically just manage them by, you know, limiting their fat intake or the triglyceride intake versus, you know, we may give them TPN nutrition just so we can control their diet inpatient versus trying to control it through other mechanisms, which patients usually don't follow. Then we got our diaphragmatic hernia. So we talked about that one a little bit yesterday or the day before. So this can be difficult, sometimes difficult to diagnose. So that's why we sometimes like to put that NG tube in. If we diagnose it without the NG tube, then we need to put one in to decompress the stomach and kind of open that lung area up. But all of them are going to have to get some sort of diaphragmatic repair. So this will be an operative patient. It may not be emergent, but they're definitely going to have an operation to repair that. And then our aortic transections, if they make it to the hospital, like I said before, we need to manage that blood pressure, or we need to manage that heart rate and blood pressure and those shear forces onto that vessel. So typically beta blocking agents are the preferred choice for these until they get that stent or graft. And then here's some indications for like our great vessel injuries. As we can see, the most suggestive finding is going to be that widened mediastinum on our chest X-ray for these ones. And then obviously if there's a penetrating injury, you'll likely have some sort of entrance wound near the base of the neck or in the chest. And then if they're in shock, that requires typically like thoracotomy or sternotomy for these patients. If they're stable enough, like we said, we can get that CT angio, and we need to reduce some of those shear forces on there. And then cardiac injury. So blunt cardiac injury is common, and like we talked about, that the right ventricle is obviously the closest to the anterior chest wall, so that's where we're going to see a lot of those injuries. And these patients, if they're stable, these are ones we're going to obviously want to get our EKG, we're going to get our cardiac markers on these patients. If they're unstable, then we need to put that ultrasound probe on there and look for any sort of, whether we have tamponade, whether we see any like wall motion abnormalities on these patients. And then penetrating usually is easy enough. You should see some sort of entrance or exit wound, hopefully somewhere near that area. And then here's our tamponade. So we got that Beck's triad, which you frequently don't see, but they typically will have one of these findings. Typically hypotension is a common one, but you might have muffled heart sounds, JVD, pulsus paradoxus. And this is one that we need to put that ultrasound probe on there and get that fast exam, looking for any fluid around the pericardium or in the pericardial sac. And then these patients typically go directly to the OR, or we might have to do a thoracotomy in the emergent setting for these patients. If we don't have surgical capabilities, so you don't have a surgeon, you're at like a remote facility, pericardiocentesis can be a temporizing measure that we can use. And then, like I said, if there, any cardiac arrest imminent or witness, then we typically do that resuscitate thoracotomy and then cut up the pericardial window. And then, all right, what do we think on this one? Yeah, urgent pericardiocentesis. Good. Now, what if it said, what if this patient was stable? What would we do? Yeah, we'd probably get a CT. I mean, theoretically, we should have a chest X-ray already, but if it was asking the next step, chest X-ray would probably be the next step in this patient, in all honesty. If you're doing like test taking 101, I said next step for this. And then let's say we get all those, they're normal, then what will be the answer? We already got a CT and a chest X-ray. Is that it? We're done? Yeah, the cardiac enzymes and EKG are going to be what we would do next. Then our resuscitated thoracotomy. So has anybody ever seen one of these? They're pretty brutal. You're cutting open typically the entire hemithorax from the sternum all the way down to the bed, and it requires a tool that I don't know the official name, we call them a chest spreader, and it's just you crank it, it opens up. We're going to practice this procedure during our advanced trauma lab on the 15th, so you guys will get an idea how this is done. And it's pretty brutal, so we're exposing the heart, and then we're also bearing down to the aorta, and we're usually putting a clamp on that aorta and cross-clamping it, just so, because they're in profound shock, we want to keep blood flow to those vital areas like the heart and the brain. So we typically clamp the aorta. Other procedures you'll see like that pericardial window if we have a significant tamponade, but if we have like profuse bleeding from one of the lungs, we'll sometimes do what we call a hilar twist, which sounds exactly like it is. You basically twist the lung and the vessels in there so that you can stop that bleeding. So that's also something we commonly do with these procedures if we see any significant hemorrhage from those lungs. And then survival, not great. Blunt trauma, it's like, around 1%. which is why a lot of the recommendations, we typically avoid it if we can during blunt trauma. You know, stab wounds, they typically have a higher survival rate than GSWs. And then penetrating has a better survival rate with these patients, which we'll look at some charts here for these different indications. No, you guys don't need to know these. These are just different guidelines that they use. So we have trauma guidelines, and they have an East guideline and a West guideline, depending on what facilities you're at that they use. And these are all rough guidelines, obviously. You know, we don't follow them to the T. So, and a lot of times, you know, you're basing a lot of it on your EMS report as well. So we probably do a lot more thoracotomies than are actually indicated, because we're trying to save that patient, and if we have the resources to do it, we will do that resuscitative thoracotomy and give them the patient the benefit of the doubt to see if we can find something that can be fixed or something we can operate on to save them. But typically, like, we like to have some sort of signs of life, you know, depending on which guideline, within 10 minutes. We'll go over the next guideline, which is the Joint Trauma Systems. That's the military's guideline for resuscitative thoracotomy, like in a theater of operation. Yeah, most of the ones for blunt trauma we recommend against, if there were no signs of life. And then here's our joint trauma systems, our absolute indications for these, like, you know, penetrating, loss of vital signs, 15 minutes, or impending arrest. For blunt, you know, if they had pre-hospital vitals and they had a witness arrest, typically by EMS, or they had pre-hospital vitals and then refractory shock and impending arrest. We shouldn't perform this, obviously, with blunt trauma, arrest before arrival, and no signs of life. We typically don't perform these. So like we said, that's the picture there is what we call a clamshell. So you're opening both sides of that chest across the sternum, and you have to cut through the sternum. We have sternal tools that will cut through it, and you're opening up both sides of the chest and evaluating the entire thoracic cavity, which commonly happens in patients we're doing a thoracotomy on. We extend it to the other side, but that urgent exploration is for that over 1,500 milliliters initially, or 200, over 200 an hour. We perform urgent thoracotomy. If we suspect any like major tracheobronchial injuries or some sort of pulmonary laceration, and we do that high-large risk, or sometimes we staple those as well. And then the esophagus is another one. If they have any sort of esophageal disruptions, that causes obviously significant sepsis, but they can expire quickly from any sort of esophageal perforation or injury from that trauma. So we tend to do them for those too. All right. Give you all a second to read it. What do we think? Yeah. So urgent echo at the bedside. Is this patient stable, unstable? Yeah, unstable, right? They're tachycardic, tachypnic. What about, where did they take that blood pressure at? Yeah, probably the femoral, right? Which one's 80 over Powell? Yeah, your radial. Good. So here's some other operative, indications. So some of these patients, if they have like that retained pneumothorax, like a post-traumatic empyema, if we missed anything, then they may have to get some sort of delayed exploration or operation for this. We do like to use those. They're using the video assisted thoracic surgery, thoracoscopic surgery there. So they're using their cameras in there, just so they don't have to open that entire chest up, because you have a lot of ribs that are in the way. So when you do this, when you're doing an open operation, it's pretty significant because you have to spread those ribs. It's going to be a very large incision. So if we can do a delayed exploration, that's typically less invasive for the patient. I mean, still extremely invasive, but less invasive than a thoracotomy at that point. So there are some of the different approaches we use there. If it's a thoracotomy, then obviously you're opening up that entire hemithorax, basically from the sternum to the bed. There are medial sternotomy approaches that they might use, and then obviously VATS is the preferred one, just because it's a little less invasive. All right, so we covered a lot. What questions you guys have? Don't worry, we've got another lecture planned. We're not done yet. Questions? Something? Anything? When's the AC gonna be fixed? I don't know. Good question. All right, take 10 minutes. Be back at 9:02, and we'll go on to the next lecture.